Hi, ladies and gentlemen, just give us a little bit more time. Our doctor is currently trying to log on. So let's give him just a little bit more time. Just be a little bit patient. Thank you.
Well, good evening. I'm here.
evening, everyone. It is 7 minutes after the hour of 7. I saw our chairperson for training and education chime in just now, but we have lost her. She will actually take us through this evening's session. So I crave your patience. I'm going to make contact with her just now, and so I'll be with you in a minute or two. Thanks very much. Thanks very much.
Good night, sir. Good night, sir.
Good night, JP Webster.
And how are you today?
I'm doing great. You?
I'm okay.
Okay.
And how are you
I speak
today?
with you shortly. Thanks.
Okay, sir. I'm okay.
Okay. I speak with you shortly. Thanks.
Okay, sir.
I'm not hearing anything. I'm not hearing anything. We are aware, Justice Andrew. We're just trying to see how best we can deal with the technical problem we're having. Kindly just bear with us a little while. We soon have the matter resolved. Thank you, sir. Justice Andrew, you heard me just now. I heard what you said. We're just trying to solve a little technical problem. It will be dealt with shortly. Just bear with us a little while.
Reverend Williams, you're very low, sir.
Okay, let me see if I can increase that.
Reverend Williams, you're very low, sir.
I'm getting a feedback. I'm not sure whose end it's coming from. I'm getting a feedback. I'm not sure whose end it's coming from.
Good evening.
Good evening, madam. We are hearing you.
Okay, you're hearing me now. Okay, thank you so much. Good evening, Mr. President Cristobal J.P. Wright. Good evening to our Honorable Costas, Lorem for the parish of St. Catherine, Mrs. Iselin Golden, CDJP. Good evening to our fellow JPs and members of the Management Committee. It is indeed a pleasure for me to welcome you this evening to our another Power Hour. And we apologize for the late start, but we're happy that you're here and we thank you for your patience at this time. You know, there are technicalities that happens and it happens at the time when you rather it not happen. But I welcome you this evening and it is my pleasure this evening to welcome also our guest speaker this evening. We're happy to have him with us this evening. And of course, we will be looking at men's health and prostate health and all of that. And we all have to contend with these conditions from time to time. And I'm sure it is a topic, you know, we have to, through our welfare department or welfare unit of the St. Catherine Justices of the Peace Association, have initiated this particular training in conjunction with the training unit. So we are very happy that for the vision, because we know that we need all of these things. We need to be educated, we need to be informed, we need to be sensitized that we can manage these conditions as best as possible and we can guide our fellow citizens in the way that they should go, where they can seek assistance, what the signs they should look for. So this evening I look forward to a very informative session and I'm sure you are doing the same. So fellow justices of the peace, I introduce to you Dr. Reaud Iqbal Gafoor, consultant urologist, BSc Biology, MBBS, DM Urology. Reaud Gafoor is a urologist who is dedicated to benign and malignant diseases with fellowship training in minimally invasive and laser surgery, urinary stone disease, urological cancers, and expertise in renal transplantation. Presently, he is a consultant surgeon with a private practice at Art of Surgery. He also is employed to the Kingston Public Hospital. He graduated the University of the West Indies, Mona, where he attended medical school, MBBS 2001, and further specialized in urology, Doctorate of Medicine 2013. He attended McMaster University and the University of Toronto for elective training during his residency. Dr. Gafoor then subspecialized with fellowship training in Melbourne, Australia, 2014 to 2016. Dr. Gafoor is member of the American Urological Association, Société Internationale de Urologie, and European Association of Urology, and is the president of the Jamaican Urological Society. He is managing director of the Elective Surgical Center, Art of Surgery. He's an avid tennis player and a gardener, but his greatest achievement to date is being a father. Fellow justices of the peace of the parish of St. Catherine, please unmute your mics and help me make welcome to this platform, the virtual platform this evening, our special guest, Dr. Reaud Lqbual Gafoor. Please welcome.
Welcome.
Sir,
Welcome.
Okay, thank you, Dr. Gafoor. Thank you for being here. You have heard the welcome that you just received. It is our pleasure to have you here this evening.
Thank you so much. Good evening, Ms. Young Palmer. Thank you for that fantastic introduction. Thank you, President Wright and Ms. Joan Pennycook Perry, and indeed the St. Catherine Justice of the Peace Association. I am very excited to have the opportunity to speak to you on this topic that's very near and dear to my heart and causes a lot of men a lot of anxiety anytime you talk about the prostate. Thank you so much for that. I believe that we will start with a presentation, and then I think we'll have some time afterwards for a Q&A session. So please let me know if you have any difficulties with my screen share. If you're unable to see it, do let me know now. All right. Okay, so we are indeed talking about prostate cancer, and what exactly is prostate cancer? Well, it's like all cancers or malignancies, it's an abnormal growth of the organ, and it's a growth that has the potential to grow beyond that organ and to metastasize, that is, to spread to far and distant organs. And it can also become life-threatening. But what is the prostate gland? It's actually an accessory sexual gland, which means that it is not vital for reproduction, like such as the testes and so on, but it does help significantly in maintaining sperm health by keeping the sperm in a fluid medium so that they can do what they need to do. Well, what are the signs of prostate cancer? How do you know that you may be developing a prostate cancer? Unfortunately, for the most part, prostate cancer is fairly non-specific in its symptoms. That's because the prostate gland is a fairly small organ, about the size of a walnut, and it's hidden way down in the male pelvis below the bladder. And you may have some urinary symptoms or blood in the sperm or blood in the urine or pain with ejaculation, but that can also happen with a lot of non-cancerous conditions like prostate enlargement or inflammations. And so, unfortunately, it's not a reliable sign of cancer. And when you do have symptoms such as significant pain in the hips or the spine or the legs, that's usually a sign of metastases or spread to the bone or to the spine. You may be unable to walk, or spread to block the kidneys, and you may have kidney failure. And those are usually bad situations where it's no longer curable. So ideally, we want to pick this up when it is treatable, curable, when it is asymptomatic, that is before you have symptoms. And that's what we're really talking about when we talk about Prostate Cancer Month, and we're promoting prostate cancer screening this month in September. And as a president of the Jamaica Urological Society, I am quite proud of the effort that association is making in promoting the word of prostate cancer screening. Prostate cancer is very common in Jamaica. It's the most common cancer that we will experience, and in the United States is the most common cancer after skin cancer. It's the number one cause of new cancers in Jamaica and the number one cause of all cancer-related deaths. So it is common and it is deadly. We have about 78 new cases per year per 100,000 population. And when you consider our population size, that's roughly over 2,000 new cases per year. And we rank among the highest mortality rates in the world, alongside Barbados and Haiti. Worldwide, 1 in 8 men run the risk of being diagnosed in their lifetime. And also worldwide numbers, 1.4 million new cases per year will be discovered. And unfortunately, roughly 20% of those patients will succumb to their disease per year, roughly 378,000 prostate cancer deaths per year. This is quite unfortunate because when detected early, there's a cure rate of over 97% in the best of circumstances. But when it has spread beyond the prostate and is not detected early, the cure rate, or the survival rate rather, is unfortunately rather low at 30%. And these numbers are similar in black men as well. We see that when black men are detected early, their cure rates are very high, and when they're detected late, their cure rates are low. Again, underlining the importance of screening for cancer. What exactly is screening? What does it entail? Well, there are two parts to it. There's a simple blood test that you should be done annually once you're of age, and a physical exam, which involves what's called the rectal exam, where the prostate is felt through the rectum. That's where it's most easily. Can you hear me now? I think I was muted. Can you hear me? Okay.
Yes, we can. Okay.
Great, thanks. So there are two things that go hand in hand, so to speak: the blood test and the physical exam. And when do we start it? We recommend that if you are not at risk, you start at 50 years of age. If you have any risk factors, that is a family history of prostate cancer, and in particular in our setting, men of African descent, and a number of other risk factors, then you should start at 45. Presently, the Jamaica Cancer Society endorses starting a screen at 40 years of age because we're at a very high risk of prostate cancer. And it should continue until you are within 10 years of their life expectancy. For the average person in Jamaica, the average man lives to about 85, so we would stop screening at 75 years of age. The reason being that prostate cancer is fairly slow growing and it takes about 10 years from when it's detected to when it would kill you. So if you're not expected to live beyond 10 years, we would stop screening at that time. And I get this question a lot. Do we have to move on to the rectal exam? Can we just do the blood test, doc? A lot of men are scared when we talk about examining the prostate gland, and there are a lot of myths and a lot of cultural boundaries that we have to overcome as urologists on a daily basis. Men just don't like showing up to have the prostate examined. Yes, we can do the blood test, but we would miss a significant number of cancers because the blood test can be normal and you can detect the cancer on the physical exam in roughly 30% of cases. Number one, aside from the missed cancers, it helps us to stage the disease, determine how advanced it is or localized it is, which will help us in planning the management and appropriate route of handling what is necessary for you. And again, it helps us to rule out other things that could mimic a cancer, like an infection or inflammation, and just normal enlargement. That practically every man over 50 or 60 will start to experience some amount of enlargement. What are our treatment options should you be discovered to have a prostate cancer? Well, the majority of cancers these days, because of screening, are being detected very early when they are what we would call indolent cancers. A lot of cancers are sleeping cancers, which means that you can watch them for many years, and the chance of them upstaging to a more aggressive form is roughly 70%. So 30% of men, 3 out of 10 men, would never have needed any further treatment other than to watch it. So that's great. That's really fantastic news, because not everyone who's detected with a cancer do you need to have a surgery or radiation or anything more radical. And the aim of this is that should you then develop a cancer down the road, it is picked up because we're surveying it or watching it closely. It's picked up way in advance at a time when we have lots of time to offer a cure. So nothing is really lost, and rather, should you suffer a side effect of treatment, you would have been spared that side effect for many years until you do subject to that treatment. So in that way, we are avoiding over-treatment. Well, what are the treatment options? The first question is it curable, or has it been detected when it is no longer curable? And so first, let us talk about the curable disease, because that is ideal. If it is not of the indolent form and we think we need to intervene, we can offer surgery. The surgery is called a radical prostatectomy, where we remove the entire prostate, the seminal vesicles, which are attached, also accessory sexual organs, and some of the nodes in the area to determine if the cancer has spread beyond. That can be done by open surgery. It can be done by laparoscopic or keyhole surgery, or these days we talk a lot about robotic surgery. At the end of the day, it matters not. The results for all three are essentially the same. With robotic surgery, you may go home a bit earlier. With open surgery, the transfusion rate is a bit higher, but what matters? Cancer cure and the main side effects, those are essentially the same however you have it done. The most important thing is to have it done by an experienced person, and as a surgeon, that is one way that I would advocate for the appropriately selected patient. For every person, we try to curtail your treatment or tailor it to you and your expectations. So for some people, surgery is best. The second option is brachytherapy, which is radiating the prostate from within, versus external radiation, where we radiate the prostate from outside. And a lot of persons will confuse radiation with chemotherapy. And if I mention radiation, their arms go up and say, "Doc, I don't want radiation. My hair will fall out and I'll get sick." No, that's chemotherapy. And the chemotherapy is ideal for certain cancers and persons with certain expectations. So it's really, again, an individualized choice. It's roughly a 6-week treatment for the external radiation, and the doctors will focus x-rays on the prostate and then burn the cancer from the outside. So not to be confused with chemotherapy. Again, how effective is it? So that depends on how aggressive it is and how early it's detected. But once it's curable, its stage is curable, your cure rates can range from 65 to as high as 95%. The main complications with surgery are urinary incontinence. So 30 to 65% of patients will have trouble holding up the urine despite how it's done, whether it's robotic, whether it's laparoscopic or open. That's the average range. 30 to 65% of patients will have some trouble holding up the urine. And that can last from up to 1 year. Most people will get better. But some people are left with some amount of incontinence to varying degrees. And there are always treatment options for that, be it medication or be it further surgical intervention or physiotherapy. There are ways to treat it. The other main complication is erectile dysfunction, and that's the one that scares a lot of men. Up to 50% of men will have some amount of erectile dysfunction. Whether it's temporary or permanent will depend on a number of factors: how aggressive the surgeon was during surgery, or what your pre-existing function was like. If you had poor function before, it's not going to get better after surgery. There are other treatment modalities that are a bit experimental and not really available in Jamaica at present, as they're not really considered the standard of care. For example, cryotherapy or freezing the prostate. There's HIFU. There's which is a form of heat intensification. There's radiation. A number of other energy forms are being used, but those only treat where the cancer is detected in the prostate. Thereby, you try to save the rest of the prostate gland. So only areas where there's cancer. The problem with that is that the entire prostate gland is prone to cancer formation. So it's really only ideal for very non-aggressive cancers. And again, it is experimental at this point in time. That brings us to treatment arm number 2, those persons who have incurable disease, where it has spread and treating the gland won't cure it because the cancer has already escaped. And for those unfortunate persons, now we're talking about hormonal treatment. That is removing the testosterone, that is the hormone that drives the cancer. This was discovered roughly 50 years ago, that the normal production of testosterone promotes prostate cancer growth. And so the two persons who discovered this, they went on to win the Nobel Peace Prize for medicine, or rather the Nobel Prize for medicine, by eliminating the testosterone by medical means and surgical means. And in this day and age, you can get an injection either 1 month, every 3 months, or 6 months to decrease the drive of testosterone to the cancer. There are side effects of testosterone withdrawal, which your urologist can go into detail with you on. But briefly, they include lower blood count and weakening of the bones and alterations of your cholesterol and diabetes and a number of other things. But those side effects are pale in comparison to the morbidity or the suffering encountered with advanced prostate cancer. Unfortunately, the cancer will eventually figure a way around the hormone withdrawal, and that takes roughly 3 years before that happens, sometimes quicker, sometimes longer. The next step, or the next armament that we have in fighting, would then be chemotherapy for more advanced diseases. And that is where we have the medication that causes more severe side effects. But overall, when you balance the suffering from advanced cancer, it's appropriate for a lot of men. every year we are discovering a newer and newer treatment option for advanced cancer. The latest is immunotherapy, where we try to get the body's immune system to fight the cancer. But again, this is not curative treatments. We're just talking about delaying the progression of disease as long as we can, and thereby mitigating and prolonging sufferation. So this is the part of the presentation that I know piques a lot of ears. People want to know, well, doc, what can I do to prevent prostate cancer? And it's important then to understand that there are modifiable risk factors and non-modifiable risk factors. Modifiable factors are the ones you can actually do something about, and the non-modifiable ones are the ones that you have no say. Unfortunately, the non-modifiable risk factors are presently the strongest links to aggressive cancer. So, the things that you have little control over are the things that will most predict whether you are likely to form a cancer, and whether you're likely to have an aggressive cancer, and whether you're likely to die from cancer. Nonetheless, let us discuss the modifiable factors. These things have a weak link, so a lot of them we don't know if for sure they are associated with development of cancer or prevention of cancer, but there are studies that are in progress, and there have been some link that has been demonstrated.
Once daily treatment to reduce TD that's number one prescribed. People taking Ingrezza can stay on their current dose of most medicines.
I'm sorry, someone needs to be muted, thanks. So the first thing that we would talk about is diet. Diets that are high in alcohol, meats, especially red meat, dairy products, fried foods, and by way of fried foods, we really mean trans fatty acids, hyperinsulinemic diets. What does that mean? Those are sugary diets, diets that cause the body to produce high amounts of insulin, or diets that you think are associated with diabetes, or sugary drinks as well, and foods with high glycemic index. Those will predispose to the formation of cancers. Dietary protein, but not necessarily animal or plant-based protein, has been associated with prostate cancer. And obesity, smoking, low physical activity, poor sleep quality, and infertility. So these are lifestyle things, except for infertility. These are mostly lifestyle things that we can change to affect our cancer risk. So we've spoken about diet and lifestyle. There are sexual activity related things. For example, for every 10 female partners, one study showed that there was an increase of 10% in the risk of prostate cancer. So if you had 10 female partners in your lifetime, your risk increased by 10%. 20 female partners, 20% increase, and so on. Conversely, there was a protective factor from increased sexual activity. More than 21 ejaculations per month was associated with a 25% decrease in risk. And a lot of men these days are hanging on to that fact and quoting it as though it was biblical verse. I don't know that I can blame them, but there you have it. I just report the facts. Single and widowed men were at increased risk, probably by the same mechanism. Vitamin D and selenium were found in a significant study, a well-designed study, to have an increased risk, so much so that the study was stopped partway before the conclusion of it was reached, because so strong was the risk of associated prostate cancer. How can it be prevented? So we talked about diet that increases the risk. What about diet that decreases the risk? The Mediterranean diet that's high in vegetables, fruits, herbs, nuts, beans, and whole grains seem to be preventative, as was vegetarian diet, soybeans, tofu. Strangely enough, circumcision, probably because a lot of viruses that lead to urological cancers tend to hide under the foreskin. That's kind of armchair logic. We're not sure how significant that link is. And some medications like aspirins and statins, those are the drugs that prevent you from having cholesterol issues. The strongest links, as I mentioned, were the unmodifiable, and there were four: family history, genetics, age, and race. So if you have at least one person in the family who had prostate cancer, died from it at a young age, you're at 2 to 3-fold increased risk. And if you had multiple partners, family members, and that relative died young, or anyone developed the metastatic cancer, you're at 7 times more risk than if you did not have that. Race: black men are at 2 to 3 times increased risk of dying from disease than their white counterparts and of having severely aggressive forms of the disease. Genetics is similar to family history, but genetics is a little more ingrained. If we did a genetic test and you had any of the genes that we have found, that we find more and more are implicated. So, for example, with breast cancer, you may have heard of the BRCA1 and 2 genes. Similarly, in prostate cancer, if you have BRCA2 gene and a number of other genes, you're at significantly increased risk of developing cancer. And I'm actually in the midst of looking at Jamaican men who were found to have advanced cancer, and looking at the genetic strain that those men had, and we're going to incorporate that into the global genetic library to see if there's anything in our genes that's different from other men who have aggressive cancer. And that's the results of that study I'm really anticipating, looking forward to. And age: the older you are, the higher your risk of developing prostate cancer. The risk really increases after about mid-50s and peaks at about the 70s, but it also happens in your 40s, although it is less common that that should happen. It's highly unlikely in your early 40s, but nonetheless it does happen in the very at-risk persons, such as those with strong genetic links. So again, you can see you cannot change any of those things. You cannot change your age, your race, your genetic predisposition, or if you have a family member. There are two other non-modifiable factors, but we again are not sure how strong those links are, and that is baldness and height. So I'll just throw it out there, but I would not lose any sleep or any hair if I was bald, or if I was excessively short or tall, for that matter. What we can modify is our likelihood of developing advanced cancer, not of developing it, but of detecting it, and that is where screening comes in. So we're less likely to die from cancer if we submit ourselves to prostate cancer screening. And indeed, the results show that screening programs around the world have been associated with up to 90% cancer detection rate at a curable stage. When we compare this to the 80s and before we started doing PSA, that's a blood test I mentioned before, most of the cancers were detected at an advanced stage. And now that we have instituted screening programs, most cancers are being detected at an early stage. Unfortunately, in Jamaica, that does not ring true, because we do not have a formal government-run prostate cancer screening program for various reasons, and most men are detected with advanced cancer. It's not just a lack of a program, but there are, again, cultural issues and boundaries that we need to overcome, as men are unwilling to have the prostate examined. So that's why we're here to talk about these myths and these cultural barriers. And let us just throw it out there. What is the elephant in the room? Why are men in Jamaica so afraid of subjecting themselves to prostate cancer screening? In my experience, the number one fear is that they wonder what people will say or think if they subject themselves to this exam. What does it mean for their sexuality? In reality, it has no implication for your sexuality, and nobody has to know that you have had an exam because of doctor-patient confidentiality. Another fear is that it will be painful, and I can assure you that I have had maybe a handful of persons who found it painful, and usually these men were having an acute infection of the prostate, and with simple screening and questioning beforehand, I'm able to eliminate those men and say, okay, let's put this off for a couple of weeks until this infection is subsided and it's not likely to be painful, and then they actually have a fairly indolent procedure. It lasts roughly 10 seconds in the hands of an experienced physician, and we're able to tell a lot of things from it. Has it spread beyond the prostate? Is it likely to be an infection, or is it likely to be a cancer, and a number of other things. So as far as does it change your sexuality, I have never had a patient tell me, Doc, after you did my prostate exam, I think that I'm now attracted to men. Or conversely, that I am no longer attracted to men, now I am attracted to women. It has never happened. It does not change your sexuality or sexual orientation. And at the end of the day, I think that it is really time that men do their part in ensuring that their family unit remains healthy, and that they can continue to play an active part in their family for many years to come. Women have been doing it. They have been going for their breast cancer screening, and I assure you that the mammogram is a lot more uncomfortable than the prostate exam. This is, well, I mean, it's coming from women. It's hard to compare because women have breasts and men have prostates, but women do compare of a higher subjective pain scale than men do at the screening exam. And women have been doing their pap smears for a very long time. So I think it is time that men play their part, and they make sure that they can continue to provide and play an active role in their family units for, as I said, a long time to come. Just to go over the common myths that people will come and ask me about. The first one is that prostate cancer surgery will end your sex life and it will cause a urine leak, and I will have to wear a catheter or a urine bag for the rest of my life. As a surgeon, I can tell you the numbers that I've given you are realistic. 30 to 60% of men will have trouble holding up the urine, but that number decreases with time, and there are treatment options for it. At the end of the day, almost all quality of health questionnaires that were passed around with men who had surgery would say that they're happy at 1 year with their urine, and they're happy with their decision. I would make the same decision again. Remember that you can always fix urinary incontinence. There are always options. There are options for erectile dysfunction, but your options to cure cancer after it has spread are very limited. Only elderly men get prostate cancer, and so this is not true. Men in their 50s, that's when the peak is, in your late 50s, and men as early as 40, as we have said before. And so you really should start screening at an earlier age. Conversely, if you get prostate cancer, you'll die of, or rather, the third myth is that if you get prostate cancer, you'll die from this disease. We've already said that the cure rate is very high. And conversely, men did not know that it can kill you. So we've also shown that it can be deadly when not detected early. And finally, well, Doc, I feel okay, so I should be okay, not having any pain. I don't need to test for this cancer. Again, we're trying to detect asymptomatic disease before you have symptoms, because that is the best time to find it. So the fact that you're okay, or you're not having any problems, and urine problems or pain is not a reason not to test for prostate cancer. right? So the take-home message, screen. If you have a life expectancy of 10 years, you don't have any other major illnesses that is expected to that you're expected to succumb from, like major heart disease or another aggressive cancer, because it will decrease your chance of dying from prostate cancer. All right. I think that covers most of the points that I want to make at this time. I hope that it has been clear and you've all been able to follow. And I am sure that there are a lot of questions that are going to be raised from this. And so I am open to Q's and A's, and there are no holes barred. Any question that you have is the right question.
Okay. Thank you so much, Dr. Gafoor. Really very informative. And must say, and of course, we ladies can help to educate and sensitize the men and to calm their fears after having heard this presentation this evening. Thank you so much. However, I will now ask that we share our questions. You may do so in the chat or use the hand raise, and I will acknowledge you. And after that, after we have completed that process, we will then turn over to our JP Kerala Morrison for the vote of thanks. But let us continue with our Q&A at this time, as I'd like to personally say thank you, Doc, for really sharing such valuable information. There's a lot of things that I heard those myths too, and they almost seemed real based on how some persons would have spoken of it. So do we have any questions? I see, okay, JP Andrew Smith, you may go ahead, unmute and ask your question.
Thank you very much, moderator. Thank you very much, Dr. Gafoor. It was indeed a very excellent presentation, I think. It's quite obvious that you're on top of your game in the field and you're very current with what is happening. I think that's very good. You mentioned that there are two types of, well, once of a better word, I say two types of cancer. Probably to consider one something benign is not necessarily cancerous, I don't know. But one benign and one being malignant. Can one being in the benign state becomes aggressive, move into full-fledged cancer? I don't know if I've asked the question the right way, but I'm sure you get the point.
Good evening. Thank you for the opportunity to answer that question, and it is a very appropriate question. The answer is simply no. Benign diseases do not demonstrate the ability to become malignant or to metastasize. They're entirely different entities. So if you are diagnosed with benign prostatic hyperplasia or enlarged prostate in common parlance, then there is no chance that that cell structure can then become metastatic or malignant. It would take a normal cell, a normal prostate cell, not one that has become hyperplastic, but a normal prostate cell, to then be under the influence of the various cancer-forming messengers to then become malignant. So if you have been shown to have BPH, then those cells cannot become malignant. However, you can develop de novo cancer, so you still need to continue to screen for prostate cancer. In other words, the cells that are there that are normal can still become cancerous, so you're still at risk but not from what has been diagnosed as being benign. If I make it, if I am clear.
Yes, I think you were very clear. Just one other quick question before somebody else get a chance is that I noticed you emphasize both the digital rectal examination as well as a PSA, but I'm not sure if you went into what the different reading suggests for the PSA, and and how critical are those readings.
Yeah, I have not gone into the range because, in truth and in fact, it varies quite a lot on what the implication is for you. Again, prostate cancer is tailor made, and a lot of the information that we garner, we're going to apply to you, the particular patient that is sitting in front of us. So if we just look at a lab form, it says a PSA should be between 0 and 4, but there's a lot to take into context. If you're a very young man, if you're 42 and you have a PSA that is 3.8, I'm going to be a bit concerned. If you're an older man, you're 75, and your PSA is 4.8 or 5, I'm not going to be as concerned. And I will take it with a grain of salt, and I will then make a decision based on a number of other factors. If your prostate is very big, because normal prostate tissue can make the PSA go up, as can inflammations, infections, and a number of other things. So we take it with a grain of salt, and we try not to belabor the patient with too much information, because it tends to cause a bit of anxiety in my experience. Patients tend to come in and say, well, my PSA has jumped from 4.1 to 4.3 in 5 years. So whilst knowledge is fantastic, I love when patients come to me armed with knowledge. A little bit of knowledge is a great thing, but we have to take it into context.
All right, thank you very much. I have another question, but I'll leave that until later on, if give someone a chance.
Okay. All right. So, there was a question that's in the chat. I have heard sitting while urinating has benefits for the prostate. Is this truth or myth?
No, I have no evidence that is so. No one has ever studied that. I do not have an explanation, a physiological explanation, as to how the two things would be related, and so I'll have to say no. I don't know of any association there.
Okay, thank you. The other question is, what foods support the prostate, if any?
Yeah, so we touched on that, and just to go over it again, the Mediterranean diet has indeed been shown to have a preventative role in developing prostate cancer, right? So that's a Mediterranean diet, which is high in beans and nuts, vegetables and fruits. Also, soya bean products and tofu products have been shown to be preventative in terms of diet.
Okay. Before I move on to, I see JP Mary's hand, but you mentioned soya bean and tofu. But is it just for men, or because I think I heard at some point that for women they should not be having the tofu and the soya bean, because it causes cancer in women. Is there any truth to that?
I'm gonna be quite honest. That is a little bit out of my area of expertise. I would prefer if a breast cancer specialist was to have some input on that. I would not like to venture and give you the wrong information.
Okay, I appreciate that. Thank you. All right, so we will go to JP Myrie. And then after JP married, we will take JP Chambers.
Okay, good night. I am sorry I'm not a JP, but I'm interested in the program. And so if it's okay, can I ask a question?
You're on the platform, so I think you are qualified to ask a question. You may go ahead, my sister.
Again, I must apologize. I did not know it was just JP alone. Is it possible that someone can have a large prostate and does not have any symptom or any pain or anything like that?
Yeah, indeed. Enlarged prostate, which is a benign disease. There is no correlation between the size of the prostate and the severity of symptoms. So you may have a mildly enlarged prostate and very significant urinary symptoms, or you may have a very big prostate and not even be aware of it. So there is no correlation between size and severity of symptoms. So you indeed can have a benign enlargement and not know it.
Okay. Why I ask is because my father died of not the prostate, but the pathologist says that because of the very enlarged prostate, as it is as big as a big fist, he said that it's wasn't treated because he wasn't complaining, so we didn't know that he was having that. We didn't know so he wasn't complaining. But what the pathologist says that is because it wasn't treated. It's so big, and it wasn't treated. It poisoned the bladder, or it infected the bladder, and the bladder that was infected now poison his body, and that what causes death. Now I was going through a really, really bad phase of that because I was saying that I have my father and did not know that he was sick. But after the pathologist explained to me and say all of that, I kind of feel like a better, but I still feel guilty that he didn't complain. And there are times when I asked him, Daddy, you alright? He said, okay, I'm fine, I don't feel no pain or anything, but it still hurt to know that he have that large prostate and he did not treat it and he could be alive now.
Yeah, first let me say I'm very sorry to hear that happened and that you had to experience it. The truth is that prostate enlargement happens so slowly over many years that there are many compensatory mechanisms. The bladder gets stronger to overcome the blockage. So remember we said that the prostate sits at the bottom of the bladder. Urine must pass through a tube that goes through the prostate, and as the prostate enlarges, it slowly but certainly blocks that passageway. And it happens so slowly. The bladder gets stronger to overcome the pressure, and behaviorally, we become accustomed to it. We don't notice that this urine is getting slower over time. We don't notice that we are feeling a bit incomplete when we finish peeing. But what really gets or annoys men is when they have to wake up several times a night to pee. That's when it really gets to them. When it gets to their sleep, that's when they start to complain, because the bladder is not emptying properly. You've always got a bit of urine left over, and you always feel like you have to go to pee. So that is possibly why he was not complaining, because it happened so slowly that he was not noticing that it was happening. And it's quite common. One day, the urine gets slower and slower until eventually you have what we call stoppage of water, and you run to the emergency room and they put a tube into the bladder and you wear a urine bag to relieve the suction and drain the bladder. To die from that is really the end stage. What it sounds like, is that he developed a urine infection. So if you dam a river with water flowing, you dam the river, you get corrupt water upstream. You wouldn't drink that water. Same thing is that corruption or infection ends up in the bladder if the urine is not draining, it's not flowing, and it's not emptying. You can get infections, which lead to bladder stones, and infections can spill over into the blood, and you can get sepsis or blood poisoning, as your pathologist was alluding to. Further down the line, you can get kidney failure as well as the pressure backs up into the kidneys. So there are a lot of long-term end-stage complications for benign enlargement, and you can also get obstruction from prostate cancer, as we're here talking about cancer and not enlargement, but you can also get similar things with prostate cancer as well. I hope that answers the question.
Okay, thank you. Now you see, this thing, when you're not complaining about pain, when you're not feeling pain, you think that all is well, and it's not. Oh, okay, thank you very much, and
again, it underlines that the women really have to help men with this. The men are often told to suffer in silence. It's part of being a Jamaican man. We suffer in silence, and it's really not necessary, is it? And again, we have to rely on women to help bring us to the doctor to kind of relay or dispel our anxieties about examination, because women have been doing it for a long time, and we really have to look to our wiser halves to save us from ourselves. And someone said a bit earlier that women are bringing men to prostate cancer screening more and more, and that's really, I'm all for that. I see a lot of that.
Okay, thank you very much. Very informative, and again, I apologize for a program like this.
No, there's no need for you to apologize, Ms. Mary. There's no need at all. The program is open not only for JPs, but you are very welcome to be here, okay? So we want to educate not just our JPs, but also our general citizenry. So you are welcome here, all right? So no need to apologize. All right, and we thank you. We thank you so much for your question, and it has opened up the doors for a very good and wide answer for our own understanding. So thank you so much, and we look forward to having you again. All right?
Yes.
All right, right there. Okay. Good night, Doc. Is eating pumpkin seed a preventative way for such cancer?
I don't know specifically about pumpkin seeds, but we do know that grains has some preventative impact. And again, the level, the strength of the association is weak. So, for example, some studies may show a 5-7% decreased risk in prostate cancer from eating certain foods like grains and so on. Seeds and grains, legumes and vegetables. I do not think that it is as strong a factor as the non-modifiable factors, but certainly there is some proof that things like that, and I'm not going to go into whether it's pumpkin seed or whether it's a different kind of seed. I don't think anybody has stratified it as such. They would probably just group everything together and say, yes, grains, yes, legumes have a preventative factor.
Okay. All right. I'm not seeing any other questions in the chat. Do we have any other raised hands? I don't think I'm seeing any other. Yes, Dell. You may go ahead and unmute and present your question.
Thank you. Good night, everyone. My question is, Jamaican men have the highest rate of prostate cancer in the world. Now, based on what the doctor had said in his presentation, that there are reasons for that. My question is, are any efforts being made to design another way of having our men tested for cancer instead of doing the rectal examination?
So yes, as I mentioned before, there's genetic testing, and if you have certain predisposing factors that are identified, if you have a family history of prostate cancer, or someone that you're related to um, has was diagnosed with metastatic or advanced cancer, a close relative, a number of other predisposing factors, then we would recommend really that you undergo genetic testing, especially if that person has been, if someone that you're related to has been confirmed to have a genetic predisposition, then you may have the same genetic predisposition. So those persons, we recommend you do a genetic test, which is a simple swab of the cheek or a blood test. They take those cells and look into it to see if you're at risk. Number one. Um, the second test that we are doing more is called the MRI of the prostate, which really is used in conjunction with the PSA and the rectal exam. And we use it more as a tool to decide what to do with an abnormal PSA or abnormal rectal exam than we use it as a screening implement. Reason being that it is far easier to do a blood test, quicker, cheaper, convenient to do a blood test and a rectal exam than to do an MRI, which is far more expensive, less accessible. We do not have enough MRIs in the island to do an MRI for every man that needs to be screened, or enough radiologists to read all of those reports. So if the PSA is abnormal or the rectal exam is abnormal, and we are trying to decide whether to move to the next step, then we will use an MRI to determine, yes, there is really likely a cancer, or no, these tests are abnormal, but it's unlikely that there is a cancer. And the next test of which I speak is called a biopsy. So none of these tests, neither the blood test, the rectal exam, or the MRI, will confirm a cancer. They just tell you, we have a suspicion, or there's a good chance that there is one. The biopsy is the next phase, which is a minor procedure. You're not put to sleep. We put a needle into the back passage or through the skin below the scrotum to enter into the prostate, and we take samples of it, really needle thin threads of the prostate, send it to the lab, and then the pathologist will look at it under the microscope and confirm the presence of a cancer. That's the only way to confirm a cancer, is to move on to a biopsy. So, it is although not a major surgery, it's a minor procedure. There are side effects and risks. It's not without its downside. You can get significant infections. You can have some bleeding afterwards, and you can miss cancers. So we undertake it only when you have a good reason to do it, and that's what all the first round of tests lead us to. Do you need to do a biopsy to confirm a cancer?
Thank you.
You're very welcome.
Okay, is there any medication to be taken to prevent prostate cancer?
Yes, thanks for that. Very good question. I mentioned in the presentation that some statins and aspirin and other anti-inflammatories have some kind of weak protective link. There are medications for the prostate, specifically for enlarged prostate. There's a tablet. There's a group of drugs called the 5-alpha reductase inhibitors. It's a long word, and you may or may not have heard of these medications. There's a tablet called Duodart or Avodart, and Fincar or Proscar. these tablets are really designed for men with enlarged benign prostates to shrink it to relieve the symptoms of prostate enlargement. So, to really decrease the size of the prostate. And it has been found in some of these studies, it's not every study, it's not a concrete evidence, but some studies have shown that there is a decreased risk of low grade or intermediate grade cancers developing whilst on this medication. However, there's no preventative effect on men from developing aggressive or high grade cancer. So we can take it for what it's worth. I am not sure on the strength of this as evidence. When you look into the details of the studies, there may be some statistical aberrations that can explain some of these findings, but I think that there's not much harm in taking them if you believe that it will prevent you from developing low or intermediate risk cancer. I have nothing against it. They also have side effects like enlargement of the male breast tissue and some sexual side effects like decreased libido. So nothing is for free, and we really have to weigh the risk with the benefit.
Okay, thank you for that one. What is prostatitis, and is there a direct link between that disease and prostate cancer?
Yeah, thanks for that question. Prostatitis is an inflammation of the prostate gland. Inflammations happen when there's been an insult to tissue. If you put your hand on the stove and you burn it, you will look at it in a couple of minutes and it's going to be red, painful, throbbing. A lot of blood will rush to the area to bring cells to fight that trauma or injury. If you get a viral and bacterial infection of the throat and you look into the back of your throat, your tonsils are red and angry and inflamed. That's inflammation. It's the body's natural response to any kind of injury. The prostate gland can get an infection, or it can just become and infections tend to bring inflammation, or it can be inflamed for no reason, for no infective reason. So prostates get inflamed acutely or long term. It can be infective or non-infective. There was a train of thought about 10 years ago that prostate cancer was developing in a number of men. And it's not all men who had prostatitis, but the thought was that a certain segment of men who had prostatitis were going on to develop prostate cancer. But that has since been quelled, I think, fairly and unequivocally. There was no strong evidence that inflammation was turning into cancers. It could be that these men were just being surveyed. Men who had prostatitis were being closer followed by their doctors and urologists. And so by chance, if they happened to have a cancer, it was being picked up at a higher rate because they were being looked at closer, as opposed to a man who was not being followed by a urologist or by a GP or a clinician. They were developing cancers, but it was not being detected. So again, a bit of a statistical abnormality. And when we really turned the eye of science to that theory, it did not really hold water. And to my knowledge, there is no significant evidence that prostatitis leads to prostate cancer.
Okay. All right. I see JP Cristobal, right hand.
Thank you very much.
Yes.
Thank you very much, ma'am. I'm not sure if you are able to see the YouTube chat, but this one is coming from the YouTube chat. So I'll just read for you.
Yes.
On June 30th, I had a PSA test, and the result was 5.83. On August 4th, I had another PSA test, total free, and the result came back broken down in 3 parts. PSA total 2.3, PSA free 0.2, and PSA percent sign 9L highlight in bold red. Now I am really confused because I read some information that state that PSA percent free is supposed to be greater than 25%, which mine is 8.695, but they rounded it up to 9%. And that is lower than percent free. PSA means that changes of having cancer is higher. That's coming from YouTube.
Right. So again, we have to take the value into context, and I would be interested to know what the prostate feels like in that patient. The fact that the PSA decreased from 5 to a normal range of 2.8, I think it was you said, is a little bit reassuring. Indeed, the free to total ratio is abnormal, but you have to take that into context. What's the size of the prostate? There are other calculations that we would use aside from the absolute PSA value and the free to total value, like the density, how much PSA is there per per unit volume of prostate. And so at the end of the day, if this patient was having equivocal findings that one PSA was high but or normal, but another reason was a bit abnormal and the prostate felt a bit abnormal, that's a person that I would probably recommend we go ahead and do an MRI and see if there are any areas that highlight in the prostate that would trigger a biopsy. So at the end of the day, I'm a little bit reassured by the 2, but a little bit concerned by the 9. But I don't think we have enough information here to really give any strong advice. There are reasons why the free to total could be low in non-cancerous conditions. So I would not get too excited about it. You probably need to see a urologist and have an in-depth conversation as to what do we do with these results? Where do we go from here? That's what I think your next bet should be.
Thank you very much, Doc. I will place information in the chat on YouTube.
Okay, thank you, Mr. President. Thank you. Okay, I think that was the only one in the YouTube. For us, I see JP Andrew again. Now, we will take your hand, sir. So you may go ahead and present your question.
Okay, thank you very much, moderator. All right, just a quick one, Doc. The prostatitis. Could you say that's one? Could you say what is it that actually causes this? And secondly, that's 2 questions. And secondly, as it relates to, I've heard of cases where all along somebody has prostate cancer and it's not aggressive, and then suddenly it seemed to just go haywire and get out of whack. So one is what would have caused the changes from being so, moving from not being aggressive to being very aggressive, and secondly, what is it that really cause prostatitis? Sorry.
Right. So let me answer the first part. What causes prostatitis? And the simple answer is most times we don't know. The causes can be infective or infectious, but the majority of cases are non-infectious. Again, it is a result of inflammation to or inflammatory response of a tissue. But in this case, most times it's a response that is inappropriate. So there's no actual trauma to the prostate. There's no burn. There's no infection. There's nothing really going on. But the prostates or the body's inflammatory cells have released a number of mediators to attract an inflammatory response. It's basically tricking the body into thinking that there is something going on. There are triggers to a man's prostatitis, and they're very far in the spectrum and realm. For some men, it is coffee. Some men, it is black tea. Some men, it is alcohol. Some men, it is triggered by cold weather. Some men, warm weather. The triggers are far and wide. For some men, it is ejaculation or having sex. Some of them can be avoided and some cannot. You can limit the amount of spicy food that you eat, but your sexual activity, it's difficult to really limit that, realistically speaking, and still maintain, a good quality of life. So it is very frustrating, the prostatitis, because a lot of times we never elucidate the eliciting trigger or cause. When there is an infection, that's a lot easier to deal with because you treat that with antibiotics by and large and anti-inflammatories. But it can be maddening for the patient who has a chronic prostatitis. The most common complaint of someone with chronic prostatitis is that I've been to so many doctors and they can't cure it. Can you cure it for me? And I'll say that's not a realistic expectation. It's difficult, if possible at all, to cure a chronic prostatitis. What we have to do is change our expectations, and we can subdue the intensity of the symptoms when it comes, but it often will wax and wane, come and go, regardless of what you do. I hope that answers the first question.
Sure, thank you.
The second question, remind me again.
The aggression, the aggressiveness of the moving from one state, right?
Why would it suddenly become aggressive? So,
right.
Are we talking about curable disease? Are we talking about disease that there was an attempt to cure and then it recurred? Or are we talking about disease that was incurable to begin with? And those are three different animals that we are dealing with. If it was always incurable, then that is the natural progression of disease of advanced cancer. These cells, they don't respond to the traditional means of controlling them after a certain time. It goes back to Charles Darwin and his theory of evolution, if you believe in that, that life finds a way to continue. So cancer cells find a way to evolve and avoid what we are doing when we withdraw the testosterone. They find a way of evolving and growing. So if you have 100, prostate cancer cells and you can kill 98 of them, there will be 2 that propagate, and they have 4, which becomes 8, which becomes 60, and then you have a new cell line of resistant cancer cells that then become more aggressive. So that's what happens in that setting. If you had a cancer that we attempted to cure, but it recurred, then it is most likely that cancer existed outside of the prostate at the time of the attempted cure. And so if it has already existed outside of the prostate, that cancer has already demonstrated aggressive features. And so it is little wonder then that those aggressive features now become demonstrated, and it really becomes upstaged, upgraded, and widespread. So that's what happens in that scenario. In the patient who has curable disease, but there was no attempted cure, the patient may have refused cure, or they were undergoing a surveillance, but for whatever reason, the cancer became aggressive during that surveillance and it was not picked up. Then what happens there is the cell line, the genetics, the chemical, on a molecular level, and a genetic level, that cancer became more aggressive. It responded to signals that the cancer was producing to really flip a switch, so to speak, from being indolent or low grade to now becoming high grade. And high grade cancers have the propensity to escape the prostate and metastasize and eventually take life.
Thank you very much. Thank you.
Okay, Rupert Walters, we take your question now. JP Rupert. JP Rupert Walters, your hand is raised. Is it that you need to feel a question or not? All right, quick question that we may be afraid to ask.
Yes.
Okay, just a sec, JP Walters, I'm coming to you. Quick question that we may be afraid to ask. Did we hear properly when he said for married couples, more sexual activity will reduce our risk? That is coming from, yes, JP Corella Morrison.
Indeed, yeah. That's what the research shows. Frequent ejaculation, frequent sexual activity tends to be protective. Why? I don't know. I don't know of any physiological reason. Maybe, getting rid of the buildup of, chemical messengers. I don't think that has been studied. Again, sometimes, the links are very weak, and it may not really be worth the time and effort and, energy and finances it would take to investigate every little link that someone does a study and comes up with. So some of these studies are tremendously involved. They require a lot of resources. I don't think we'll ever know the answer to that, but it's one that the men tend to hold on.
Quite encouraging to the men.
Yeah, and they wave a flag with that one on it.
Okay, thank you. I must go, but I wish to say how very thankful I am for this presentation. The doctor communicated with consummate ease and clarity. We should bring him back. So that's another comment from JP Abrahams for you, Doc. Yes, okay, we'll take you, JP Walters. You may go ahead with your question now.
Thank you, JP, young panel. Doc, good night. Can you clarify for me the difference between chemotherapy and radiation, or if they are one and the same?
Yes, thanks for allowing me to make that distinction, because I often have patients who come to me with an apprehension of radiation. I will go through the pros and cons of the various forms of treatment to cure cancer, which we identified earlier: surgery, radiation, and be that either external or internal radiation, and more, but experimentally targeted therapy that's not treating the whole gland, but just where the cancer is. And sometimes someone may not be fit for surgery. They may not want to risk the side effects of surgery, or they may have known someone who had surgery and they're coming with this apprehension, and they don't want to experience, they don't want to have the same experience that their colleague did. Maybe that person had a complication or whatever. So I will tell them the other option is radiation, and as soon as I mention radiation, the barriers go up. No, doc, I know someone who had radiation, and I mentioned this earlier in the presentation. The common thing from the says, this person I know, their hair fell out, their nails turned black, they lost weight, they got sick, they threw up all the time, and then they died. But that is not radiation. That's chemotherapy. And I'll get to I'll get to chemotherapy in a second. Sorry. Radiation is really an attempt to cure the cancer, just like surgery, whereas chemotherapy is an attempt to control advanced cancer, so it's not a curative attempt. Radiation comes in forms external and internal. The external, that you lie on a bed for every day for about 6 weeks for about half-hour treatments. A lot of times people are reading their iPad or reading a book or something like that, fall asleep, and they focus radiation beams on the prostate using high technology to map out the prostate. They use CT and MRI, and they take into account how you breathe and as the prostate as you breathe. So it's very high tech stuff. They burn the prostate from the outside. The side effects: you can get some irritation of the skin. You can get some irritation of the bladder, so you may find that you have a new onset of bladder issues, peeing often, or having to rush to the toilet, or difficulty controlling the urine or stuff like that. You may have blood in the urine, blood in the back passage. You may have irritation of the colon and irritation with stooling, and the side effect profile is different from surgery. They are similar in the erectile dysfunction rates. So roughly 50% of men can have ED after treatment, and that depends on if you had it before or after. Some men, a lot of men have no ED, and some do. But incontinence is a lot lower after radiation than after surgery. But you do have this irritable bladder and irritable bowel syndromes, and years down the road you can have blood in the urine and blood in the stool. Fairly well tolerated. Contrast that with chemotherapy, which is for incurable disease, men who are going to eventually die from their disease. And chemotherapy really attacks the cells of the cancer, but unfortunately also attacks some of the cells of the body. So the hair falls out, your nails can turn black, you can develop some issues with skin and swollen tongue, and there are a number of side effects. Men do die whilst on chemotherapy, but usually those men would have died from the cancer. And so the chemotherapy is really great at prolonging life. That has been shown. It prolongs life, but it's limited. Maybe a year, maybe 2 years, that kind of area. So if you're on chemotherapy and you die, chances are you are going to die without the chemotherapy anyway. So chemotherapy gets a bit of a bad name, but generally it is successful in decreasing suffering and prolonging life. So I hope that helps to clarify things in your mind.
Just a follow-up, doctor. So would you say that radiation is more targeted, so to speak,
than
as it relating to the cells? Since you imply that chemotherapy kill both positive and negative cells, radiation, you would say, is more targeted to the negative cells?
Absolutely. It's focused on the prostate, and as technology gets more and more advanced, it becomes better at hitting only the prostate or anything around the prostate that you intend to hit. So if there are nodes are the body's policemen. They suck up cancer, they suck up inflammation. The older people would call them wax and canal, I think they call it. If you get a sore throat, you feel a lump behind the neck here. Same thing in the pelvis, the lower tummy. If there's a cancer of the prostate, those nodes get enlarged. So you may want to hit those with radiation. You may want to remove them surgically. All right. So yes, radiation is targeted to what you want to hit, and chemotherapy is systemic. It's a systemic treatment. There's no way to affect only prostate with chemotherapy. That is why we're getting newer and newer modalities of treatment like the immunotherapy that I mentioned. Immunotherapy is a lot better at targeting prostate cancer cells specifically. And so, every year it seems as though we get a new class of drugs. It's really a very exciting time for advanced prostate cancer because the options are more and more, and we can tailor our options to that individual patient. I keep beating that point. We can tailor treatment to this patient that I have in front of me. So, depending on your genetic predisposition, depending on your expectations, depending on your family history, depending on what treatment you've had before, this treatment is appropriate for you versus another one is appropriate for somebody else. So we are getting better in treating the advanced cancer only and not the whole body, but chemotherapy is systemic therapy.
Thank you, Doc.
Welcome.
I am not sure what happened to GP Young Palmer, but we'll take.
Are you hearing me?
Go ahead, no, ma'am, please.
Okay. Yes, prostate cancer come in stages. Does all stages comes with the same symptoms?
No. The earlier stage diseases tend to be asymptomatic. You may have symptoms of enlarged prostate, such as difficulty peeing, blood in the urine, blood in the sperm. But again, it's not specific to cancer. You can get those with enlarged prostate issues. Advanced cancer, the symptoms are quite different. When it is metastasized to the bone, you can get excruciating bone pain that is difficult to treat with opioids. That's very strong painkillers, the ones that you hear about that are addictive and they've got side effects like pethidine, morphine. Even those medications can't really control the pain you get when it spreads to the bone. When it spreads to the spinal cord, you may suddenly be unable to walk, and that's not reversible in a lot of instances. So you're wheelchair or bedridden, and that can be permanent. You can have, blockage of the kidneys and develop kidney failure, and you have to live with tubes to drain the kidney. And the significantly decreased quality of life associated with wearing a urine bag, either the one that goes into the bladder through the urethra directly, or the ones that hang out the side and go into the kidney. That's significantly decreased quality of life when that happens. So the symptoms of advanced disease are quite different from the symptoms of early stage. And not to belabor the point, the symptoms of early stage, often they're no symptoms, asymptomatic, and that's why we do the blood test and the prostate exam, because it picks up cancer years before it becomes symptomatic and incurable.
Okay, thank you. So our final question for the evening, JP Caroline Hall, you may now present your question.
Pleasant good evening. My question is sexual activities with over 10 females causing you to have the prostate cancer, and sexual transmitted disease, how does it contribute to the prostate cancer? Can you expand more on a man with multiple partners, like 10 female would increase 10% of the risk of prostate cancer? Because some male would say, oh yes, having a lot of sex, but how do you explain the 10 female in that situation?
Unfortunately, I cannot. That is one of those epidemiological results that we've got from looking at large populations and trying to draw, make sense of it all and looking at different factors. Was it men who wore red shirts? How many of those men developed cancer? Was it men who went to the doctor often, or what have you? There is no real credible physiological medical explanation as to why multiple partners would lead to someone developing high grade prostate cancer. A lot of times these are inferences, and they're what we call confounding factors that lead to a conclusion that was not necessarily elicited in that study. For example, and these biases, there are different types of biases in statistics. They're just saying that there's lies, there's damn lies, and there's statistics. So you can literally use a statistic to prove anything that you want, really. It could be that men who had multiple partners, multiple sexual partners, were less specific about health care, about going to doctors and checking themselves out, and so they were less likely to test for prostate cancer. And so when they were discovered to have a cancer, it was discovered at a later stage. That's just a hypothesis, but I'm more using it as an example to show you that there are many explanations that are not directly cause and effect. They are more confounding factors that lead to the conclusion that you find. Because credibly, I don't know of any way that I could explain the two things. The link to viruses, STDs, yeah, there's no strong link that I'm aware of that STDs cause prostate cancer. It has been linked to other urogenital cancers, so like the HPV and various subtypes of it is linked to penile cancer, and that is why circumcision has a preventative effect from penile cancer. There's never been one documented case of a circumcised man developing penile cancer because viruses hide underneath the foreskin, and so that leads to direct carcinogenic or cancer forming effect on the skin right next to it, which is the foreskin. But I have no explanation as to why a virus under the foreskin would then lead to prostate cancer. So it's not related. And I know of no sexually transmitted viruses that lead to a prostate cancer. That's not been proven at this point in time.
Okay, all right. Thank you so much, Dr. Gafoor, for really expanding and expounding on the subject area of prostate cancer this evening. I really want to thank you so much for sharing your expertise and your knowledge. We have truly been informed, and we are very happy to have you. And as one person said, we will have to get you back again. So we'd like to also thank the Welfare Department of the St. Catherine Justices of the Peace Association for also initiating this evening's presentation in terms of, suggestion for this really, really valuable information that was shared. I, however, will now turn over to my colleague, JP Corella Morrison, to give you the official vote of thanks. JP Morrison.
Thank you, JP Sharon Young Palmer. First of all, a little bit of advertisement. Dr. Gafoor can be found at the Art of Surgery, 10 Ripon Road, Kingston 5. And his numbers, the number I'm seeing here is 876-960-8112. And I think after this presentation, we all understand now. I think we need to go and see him. Dr. Gafoor, we want to thank you so much for spending the time. I'm sure you could have been in surgery anywhere else to speak to us, to have this kind of discussion. talking to us about this issue that we men tend to play with. For instance, I tell you, I'm afraid of needles, and I am also afraid of going to see my doc about the same issues that we have. So every time I go and I hear that, okay, we need to draw your blood now, I run. And so my wife has to be on top of me. So we want to thank you so much. We want to thank our Custos, Iceland Golden CDJP. We want to thank our association president, Christabel Wright, for leading such a proactive team. Our host, Sharon Young Palmer, JP, she has always an awesome job, hosting these events. We want to thank our special guests that are not JPs that have been on the platform, especially Mrs. Myrie. Thank you so much as being a woman, being that strength, that tower that comes out for us men. We need people like you and all the other participants and people that are not JPs on this platform. Dr. Gafoor, I am sure you're going to see a lot of us privately because we're going to be contacting you, we're going to be calling you, we're going to come and see you, because this information this evening was awesome, and we thank you so much for spending that time and having this discussion with us. And for everyone else that's on the platform, we thank you all for taking that brave step, for coming out, listening, asking questions, being a part of the discussion, because a lot of us, we men are cowards, and I am the first one. I am a coward. I am saying it. And from tonight, I'm going to try and hide and come and see you, Doc. So I can be the first to step out and says, yes, I'm a brave man. So thank you all for coming tonight. Sir President, just in case you want to say something.
Good night, sir, once more. Not at all. All have been said this evening. Really appreciate the persons coming out, more so our doc, who gave this presentation to us. So basically, that's in a nutshell for me. Really appreciate the team. And thank you very much, Prof, for hosting us as well. Professor Young Palmer, thanks very much.
My pleasure. And just remember, JPs and our friends, is there a topic that you'd like to have discussed or you'd like to hear more about? Just let us know. Contact our president or anyone of our members of the executive team or the training and education department of the St. Catherine Justice of the Peace Association, and we'll be happy to source the right persons like we did this evening to also present to you in its entirety whatever topic you are so desirous of having us share.
Patrick Brown's hilarious comedy.
Have a good evening.
Down.
God bless you all.
Sorry, JP Young Palmer, before you go, Doc, are there special times for anyone to contact you, to reach out to you, or just call your office?
I think the best is to call the office. I often don't even know what my schedule is. I think.
Right. That's last from me, JP Young Palmer. You may take over.
Okay. All right, my fellow justices and our visiting friends, thank you so much again for joining us, and special thank you, Doc, for being here. God bless you. And my friends, have a good night, and may you rest well until the morning. God bless you all. Peace unto you.
Yes, you do. Not lessons and frustrated, and to the doctor, very informative, very good.
Well, we can't invite Laila and Fire over for play some Ludi.
Laila who? Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Well, we can't invite Laila and Fire over for play some Ludi.
Laila who? Fire. Thief in fire. Who when him chop spit a fly out of him mouth like road spray.
The man
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now press high.
Thanks.
Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man...
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You're going like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now perspire.
Patrick Brown's hilarious comedy, Lockdown.
The two of us just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man...
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You're going like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now perspire.
Patrick Brown's hilarious comedy, Lockdown.
The two of us just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man...
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You're going like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now perspire.
Patrick Brown's hilarious comedy, Lockdown.
The two of us just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man...
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You're going like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now perspire.
Patrick Brown's hilarious comedy, Lockdown.
The two of us just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man...
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You're going like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now perspire.
Patrick Brown's hilarious comedy, Lockdown.
The two of us just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man...
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You're going like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now perspire.
Patrick Brown's hilarious comedy, Lockdown.
The two of us just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man...
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You're going like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the Ludi board in front of him. And me sure him knows every house now leak. And the Ludi board now perspire.
Patrick Brown's hilarious comedy, Lockdown. Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of mouth like road spray.
The man.
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the loody board in front of him. And me sure him knows every house now leak. And the loody board now perspire.
Thanks.
Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man.
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the loody board in front of him. And me sure him knows every house now leak. And the loody board now perspire.
Thanks.
Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man.
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the loody board in front of him. And me sure him knows every house now leak. And the loody board now perspire.
Thanks.
Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man.
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the loody board in front of him. And me sure him knows every house now leak. And the loody board now perspire.
Thanks.
Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man.
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the loody board in front of him. And me sure him knows every house now leak. And the loody board now perspire.
Thanks.
Once more, JPs. So
Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man.
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the loody board in front of him. And me sure him knows every house now leak. And the loody board now perspire.
Thanks.
ask your zone representatives for those tickets.
Patrick Brown's hilarious comedy, Lockdown.
The two was just lock up in the house like house rats. Why we can't invite Lila and Fire over to play some Ludi?
Lila who? Fire. Thief in fire. Who when him chat, spit a fly out of him mouth like road spray.
The man.
We don't want them in our bubble. I saw this virus spread by bodily fluids.
You go like him a walk around and spit pan people for spite. The man probably not even know say
Him know him is a sprayer. He must see the pugler mouth water on the loody board in front of him. And me sure him knows every house now leak. And the loody board now perspire.